Okay, cool. All right, so my name is Lacey Runyon. I am a student in Indiana State Doctor of Athletic Training Program, and me and my friends and colleagues and peers will be performing SI joint provocations tests. So I'm going to perform the sacral thrust and the thigh thrust. So my patient is here, lack of table, so my lovely patient will be my husband. Can you still hear me?
Mm-hmm.
Yes? Okay.
Yes.
So my patient is of large stature. He's a tall and very broad gentleman. So you're going to watch me heft him around and hear my kids knock on the door. So he told us to position ourselves on the opposite side. And then we're going to reach under to palpate the SI joint. And then put pressure through the femur to see if you can feel that pressure on the back. So you're trying to elicit pain, pressure you can relax on, pain or pressure in the SI joint as you do that. Obviously, we always want to test bilaterally, but for the purposes of this, we're going to do this, and then we're going to run away because my kids are kicking on the door. So the next test, I'm going to have him roll over into the prone position, and I'm just going to locate his, they are kicking the door down, locate his PSIS and place pressure just anterior or posterior to anterior through there. Again, we're trying to elicit, she's saying hi, yeah, elicit pain or pressure as we perform this test. And again, we want to perform bilateral. Hold on, let me release her.
Okay, that was good though. I heard everything, so.
Good. You want to come say hi to our friends real quick?
Hi.
Okay, go away. All right, Tara Lynn, you're next.
I'm next. Okay, sorry. Let me get my patient really quick. He's on the phone. Can I use you for a second? Oh. Lacey, your girls, they crack me up. So just like on your back right there. Down here. Head down there. Sorry. Okay, so, okay, we're doing, let me see if you can, how about you hold this like that? Okay, perfect. Sorry, this is a very awkward camera angle. Can you hold the laptop? Perfect. Okay, so this is the distraction. So what you're going to do, one hand on each. They should only have two, so I don't know why I use the word each. Either ASIS on their hips. And so you can go like this or like this. I like the cross hand better. And you're just going to kind of like distract. So that's what your hands are doing, kind of like motioning apart those two ASIS. And I forgot to introduce myself. So I'm going to introduce myself while I'm here. I'm Tara Lynn Dodds. I am a student in Indiana State's Doctorate in Athletic Training Program. I forgot what program I was in. Okay, so next is the compression. I'm going to have you lay on your side facing me. Okay. Good? Good view here, people? Yes. Okay. So, are you able to hold that? Gymnast. Good job. All right. So, it doesn't really matter what side of your patient that you stand on, but you're going to compress the, well, both sides, but we'll say this is his affected side, and you're going to press right on that side, just perfect right there. Moderate amount of pressure. So you're looking in both of these tests for reproducing the symptoms. So whatever their symptoms may be. And we'll have you go on your back again because I like to make you roll around. Okay, so this is going to be the straight leg raise. This is very difficult. Can we see? Yes. Okay, this is difficult. Okay, so we're going to do the active straight leg raise. So I'm going to have you, you're just going to lift your leg straight into the air. Good. And again, looking for that reproduce symptoms. All right. Thank you, sir.
All right, so I am next with our last two special tests. I am Megan Bibler. I am also a student of the Indiana State DAT program. I have my patient here. We're going to go over the Gangling test. It's also testing for SI joint dysfunction or any other issues with that. So what you're going to do is you're going to have your patient lay with their side that is affected hanging off the table. You can have them at an angle if they want to be more stable on the table or not. So you're going to have the affected side hanging down, and then you're going to take the other leg and take it to 90 degrees flexion, and then you're going to push down on this leg hanging down and just have a nice little stretch. It is positive if it reproduces any symptoms they've been having or provokes any pain along with that. The next one I'm going to talk about is the long sit test. So you're going to have your patient fully back on the table, and you have their legs bent at 45 degrees, and you're going to have them bridge up to the ceiling, good, and then bridge down. And then you're going to take their both left malleoluses and extend their legs. And then now I'm looking at both of the ankles and seeing if their medial malleoluses are even with each other. And after that, so hers are even, so that's good. If for some reason they are off, that could indicate an upslip on either side. And then I'm going to have her sit up straight. Okay, and then you're going to straighten out the legs again and look at the malleoluses. If they were both even and one ended up becoming longer, let's say the affected leg became longer, that is an indication that she has a posterior rotation of the ASIS in the pelvic area. And then if one becomes, or started off longer, became shorter, then that's an indication of anterior rotation of the hips. The test doesn't usually cause much pain. It's more looking at the alignment of the limbs and how their hip can be affected or pelvic can be rotated. And that's what I have for you.
Bravo, very well done.
Thank you. Okay, I'm going to release my patient from the conversation if she wants to.
Bye, guys.
Bye, Kristen.
Okay, so I guess we can just go through, and do you want to just start off how we start with Lacey's and add in your own comments on if you used them before, if you like them, what we've read in the articles?
Yeah, let's go ahead and do it. I have not used the thigh thrust, the sacral thrust, mainly because I guess I didn't really think about the thigh thrust being used for SI joint.
It froze.
Okay. Lacey, you're frozen right now.
No.
Okay, fine. I just heard no. So there, you're back on it. So I got to the point where I heard you say you hadn't really used sacral thrust for an SI pathology before, which I agree because I haven't. Before reading these articles.
Thrust.
Wait.
Oh, technology.
So internets.
Yes. Okay. For the thigh thrust that you showed us, in a couple of our articles that we read, that was one of the most sensitive tests, I think. Until reading these articles, I think I'd kind of almost forgotten about that one. I hate to say it because it's a good test. It's shown to be a good indication of SI joint issues. So do you guys use that a lot in your evaluations for SI pathologies?
I don't
No,
either of those.
Yeah, I'm going to start doing it, but I haven't been.
I had used the sacral thrust. I'd used where you put pressure right on like one PSIS or the other. but not the thigh thrust. That was a newer one for me.
You're right. Yeah, I think I've used the sacral thrust. I don't think I use it often.
Oh, that was the name of it, though.
Me neither. I always thought it. Yeah, I learned it as it like sacral apex pressure. Something, I don't know, something stupid.
So Tara Lynn, yours were compression and distraction, and those were. I mean, I remember those. I used those before. I have a hard time sometimes when I'm doing the distraction test with patients that all they're doing is focusing on the pressure of where my palms are at, and I don't think they give me a good indication of like their pain in the backside because they're too focused on that.
Mm-hmm.
So have you guys ever like done anything different, or I guess like I was thinking about padding when I was practicing. I was like, I guess I could put like towels down or something, but I don't know.
Yeah, I think the only thing is to have like a conversation with your patient first, saying like, okay, there's gonna be pressure, but I really want you to focus on how does this affect like the back. You know what I mean? Like you almost have to like preface it with like a little disclaimer. A lot of pressure on like the interior part of your body is gonna, but
patient education. So I know the distraction one, if I'm getting this correct, was the most.
Yeah, so compression, the distraction compression, and straight leg raise. So like I personally, like I use a straight leg raise a lot. I mean, not necessarily an active straight leg raise, but a straight leg raise. I don't know. I don't think I tend to do a lot of these like SI tests in general because I think I tend to look more towards the back, to the back for like SI pathology. Like I at least I haven't found very many like true solely SI problems. Like I feel like it ties a lot to like the lumbar spine, and sometimes if you just like treat the lumbar spine, it kind of just clears up. So I think that like maybe these are ones that I could add in to maybe like make my evaluation a little bit better.
Yeah, I agree. I don't use the straight leg raise because I guess I don't know why I don't use it, but I just think raising my leg and causing pain, like I think before doing this conversation about the SI indications, I was a little confused on what pain with straight leg raise was indicating for. But now I'm definitely more aware of that it's can indicate for, I mean, lumbar issues, but also SI joint.
Yeah.
Let's see here. The long sit test, I used that a lot, but it was very helpful reading the articles to get, or I think it might have been in Dr. Powden's, maybe one of our discussions, the posterior and the anterior tilt, I think, or rotation, that can confuse me a lot. And for some reason, this time it's just clicked that when it goes short to long, it's a posterior rotation because the placement of the femur when it's posterior rotated. So I think I finally have that down now, but it took a while.
Well, we lost Lacey.
We lost Lacey. I was wondering if we had lost her because
she was like frozen
for a while. Yeah.
I will continue on your talking point. I think I use the long sit, and I do like the way that, like you said, like that just helped the like short to long versus like long to short. That kind of helped me at least like straighten, because I feel like I'm kind of like trying to like, okay, well if it's this way then I'm like that, and then I just look like I'm playing with a Rubik's cube that like doesn't exist. Mm-hmm. And I think that's just an easier way to just think about it.
Lacey, we lost you there for a second. Are you back? Oh, you're muted.
Yep.
I'm not sure what's going on. It's saying like that there was an error.
Okay. Well, you keep working on that and we'll keep. Oh, wait. You're muted right now. No, you're not.
Am I frozen?
Let it go. Let it go.
Okay, technology this evening.
It's fine. It was going to happen to one of us, probably.
Yeah.
More than likely. With the long sit test, I've used that a lot, but not necessarily for SI joint stuff, like where I think about SI joint pain, more like dysfunction, where I'm looking at like length discrepancy or rotations or whatever you want to call them. I don't use ActiveNet a little bit so much for SI joint as I do for other.
Yeah. I mean, like when I'm doing an evaluation and someone's complaining of lower back pain, it's inevitable that I'll probably check long sit test just to see if anything is going on right there. I think we've gone through all the special tests. You guys want to hit on them more, or do you want to talk about what we found in the readings?
We can go to the reading.
Oh.
Lacey, did you say you want to go to the readings?
I'll take that as a yes.
Yeah, I think so. She's paused right now. Okay, so what did so the first article that was in the section, I want to know the name of it. It was Lost Slut was like the article, the author.
Okay.
I really liked that article. It just kind of helped me focus in on my evaluation. I think sometimes with SI, I get stuck on the history and their mechanism and where their pain is, and I kind of just narrow in on the SI, but I sometimes forget to do, not forget, but don't really add in special tests a lot. I just I just take a good evaluation, see what their pain is. And so that article, it helped me know what tests were relevant and specific to like if they're actually doing what they're doing. And so knowing that the thigh thrust was one of them, and I had never really even used that, was definitely an eye-opener. And so next time I have a patient, I want to try to do that, start adding that in. And also the distraction test, that was a good one for sensitivity. And I think I also read at one point in time, which stuck with me, is if you do those two tests first and they both have like indicate pain and symptoms that like recurring symptoms, it's not necessary to do all the other SI tests because you're just going to keep putting them in pain, and those are the two that have the highest specificity and sensitivity. So that was a good reminder. Like, okay, yes, I got 2 positive tests, and those are the most reliable ones. So why do I need to keep putting them through the other 4 or 5 tests?
Right. Like, I thought that was like what I liked, I think, most about this article too, is it's kind of like narrowing down, because it's like there's so many SI tests out there that, like, at least for me, like as a new clinician, like it's helpful to kind of get like my go-to, you know, and it's like, let's maybe use our time a little bit more wisely instead of like going through like every single test known to man on like the SI joint, like, oh, positive, oh, positive, negative, you know, like get your ones that really matter and then kind of go from there. And I think that's like, I think my biggest take home from that article is just, you know, which ones are good, which ones are meh. So
yeah.
I thought it was good. Going back, and I'm on my phone now, so we'll see if this.
Oh, so much better.
I thought that it was interesting that they said that it's possible some of the tests they did later could have had like some like false positives because they were putting so much pressure on the SI joint. And I think that that's another good reason to have like your go-to tests, right? Because if you're going to continue to like just stress and stress and stress something that's already painful, like you're going to have more positives and also be causing your patient more pain. Like I suffer from like SI joint pain, um, especially like I don't know if I did something terrible to myself while I was pregnant. I don't know if like the weight of my children really just beat the crap out of my SI joint.
That's a thing.
Yeah, it is. And since then, I do tend to like, especially if I'm not being very like conscious about like my pelvic tilt and just little things. I do notice that I have pain, and I would be really pissed off as a patient if someone was like, "Well, I think it's your SI. Did that hurt?" And I say yes, and then they do 5 more tests
Yeah.
for me. And like I said, I know for a fact that it would get more painful as I go on. Husband and I practiced our tests, and he's had back surgery, L4, L5 disc issues, and so just practicing with, like, they didn't cause pain when I did it, but then when he got up and afterwards, he's like, "Oh, now it's a little sore." So I think it is nice to have like it was an algorithm that just said like do this, and then maybe you're gonna have to do one more test if the thigh thrust and the distraction aren't positive. You might have to do the compression. And so I thought that was a really good article. Of the articles, I thought it was the most beneficial and clinically applicable.
That's what I thought. And I noticed in like at least 2 of the 3 other ones, that article was referenced. So it's good. They did a good job with it, I thought. Oh, I just had something I wanted to say. Oh, I was Brian's patient today, and my SI started hurting after he did the test.
Oh, yeah.
So then I was thinking about it because it wasn't during the test. So I wonder if, like maybe if you don't have pain elicited right away, like during the test, if pain afterwards, like how do you read that, I guess?
Yeah. Well, that's like similar to like lumbar mobilizations. Like sometimes like for a case in point, so like my boss is a physical therapist, but he has an OCS residency so that's like I don't know if you know what that is, just like a additional certification under physical therapy that they can get. It's more like orthopedic specific. And so he was using me as like his little practice dummy, and they were doing like thoracic and like lumbar mobilizations, even though they're like licensed physical therapists. Like my back killed me for like 2 weeks, and it was like, you know, you're just like sore. And I don't know if that's maybe just some of these tests in general where you just have, you know, like so many nerves and just sensitive things right there that it just, you know what I mean? Like you get some achy.
Yeah.
And what to do with that, I don't know.
Say sorry about your luck.
You have to think about that. You're trying to mobilize an area that like probably isn't very mobile, and the way that you're doing it, so you're stressing the ligaments beyond how they're going normally stressed. And so, I mean, it's one of those things where like, it's like if you had someone who you thought had a high arch, but they weren't complaining about it, and you tried to like fix it or put like an orthotic on them or something, they're going to have pain because of that. And I kind of equate that to this, right? Like, as we evaluate our non-symptomatic patients and even our symptomatic, you know, our non-symptomatic victims, if you must, or our actual patients, I mean, like a lot of times you see like that lack of mobility, and that's part of their problem. And then when you move it through your proprioception test, then they're going to be more sore later because now I forcibly like made this joint that's stiff on you move. And so I think that probably makes sense as to why they have some pain and soreness later. And probably is an indicator that they probably have some sort of weakness or whatever there. But I do just think like the ASIS and the PSIS, like those joints themselves and the SI joint, like they tend to be tender when palpated and tender when manipulated. And so I think that's another good reason to follow this, like, hey, let's get our 3 positives and move on. Because it is just an area that tends to be very tender. Just thinking of that. The other article that was like the lit review, I found it. I wish I would have read that first because it was so underwhelming after reading the last lit article first, which is the one that came up with like the algorithm.
Yeah.
I read that one first and then read the lit review and was like, yeah, duh, they already told me that in the last article. I knew this.
I literally just read the same thing.
It's like thanks for nothing. Well, not nothing, because they just talk about other tests that are probably not as good indicators, like Jurgensen's, or what was the other one, Patrick and Faber, that are not as sensitive or specific, and they don't have a positive predictive value or whatever it was. The although I did my assignment like an hour ago.
Oh, yeah. So I like the first two. Those evaluation articles were easy for me to read, and even the glute strength and hamstring length article was, a pretty easy for me to read. But once I got into the muscle thickness and me trying to wrap my head around like what they were actually measuring, that took a little while for me I like read through like 3 times, and I'm not sure if I
Wasn't you?
Yeah.
Wasn't just you.
As the first 2 articles were like for evaluation, right? Like,
Yeah.
And I take it as those 2 articles are identifying underlying causes of SI weakness. So gluteal weakness, shortened hamstrings, and then that long list of like associated musculature of like obliques and multifidus. I mean, multifidus, this has been tied to low back pain and SI dysfunction for a long time. I mean, there's all sorts of research out there that talks about that. So I kind of took it as like, once you've identified SI dysfunction, then we also need to identify like what's causing it. So that's the type of musculature it should just be like, oh, I should check on these things as well. Like, do they have weakness of these muscles? However, some of those muscles we can't like really physically test or separate out to say like, oh, it's definitely this muscle or definitely that muscle. But I think it's just an indicator that you have to do core strengthening for people with SI joint dysfunction. You have to address gluteal weaknesses. You have to address hamstring flexibility, or as soon as you're done with your manual therapy for stretching or whatever, they're just going to go back to where they were previously.
Yeah.
Hamstring and weakness, and be in the same boat in 5 days time.
Yeah, I appreciated those articles. I think it just makes you think more of, okay, so what do I need to focus on after I actually find out what the SI pathology is? Because I guess just, I don't know if it's not even a new clinician thing, but I think just for me in general, finding out core mechanics takes a while for me to get a hang of it. And I've worked with people who, put one hand on the glute, one hand on the hamstring, have them do a hamstring curl and see which one's firing correctly. And I just want to get more familiar with that so I can help out my patients that are struggling with poor mechanics, which then cause injuries. So I thought those articles were definitely helpful. They were just a little bit, took my brain a little longer to get around.
Like LS and GS, and I was like, just not be so scientific with it. Can we just put it in layman's terms, even though I'm a professional?
I know.
Who's also like just a chick who needs you to speak English.
Just get to the point, right?
That's really funny that you said that. Last DAT weekend, I was talking with Danny Mora, and Mora was talking about how she'd done all this stuff with like gluteal firing versus hamstring firing. And then her and Danny were like laying on the floor trying to do exercises to like fire one, then the other, and some different things like that. So we were in the same. Just little things like that, though, are really important. And I think that a lot of times we forget about those things and forget about those exercises that we can have our patients do. Important to address the underlying needs. I felt like when I was writing my paragraph, the reading assignment, that I was like just saying the same things over and over again in each paragraph. I was.
Yeah. I think like working with high schoolers now, I'll tell them to just do a simple squat, and then I look at their form. I'm like, holy crap! No wonder you are like not okay right now because you're so scary. And so I think I've become more aware of core mechanics, but I need to dive into just learning more about it, because I think that's such a huge role in injury and injury prevention also. So
It'll come.
Hopefully.
I don't feel like 100% comfortable with it even now, but I also had to do like some ergonomic stuff for the hospital that I worked for, like safe lifting and other things like that. And so I feel so much more comfortable because of that than I did just like coming straight out of undergrad being like, oh, let's evaluate everyone's like squat mechanics or walking mechanics or even just like functional mechanics or something they're doing that's sport specific. I mean, I definitely didn't feel comfortable with those things really early on.
Yeah. Well, that's good to know that it will come.
Yeah. Well, that's how I feel too, Megan. Like, I don't feel like I'm like 100%. Like, I feel like there's little things that I'm starting to like get, but like there's still like a long ways to go to be like, oh yeah, I'm comfortable. I got this. I'm kind of like, I think I got it. Kind of.
Yeah. Like that's how I was saying earlier with the long sit test. I mean, I've done it and I've always felt, but now I for some reason I was echoing there for a second.
Well, and all of a sudden, like my volume went crazy too. So
okay, maybe that was. I could hear myself, and I couldn't finish my sentence. Okay. Did you guys want to talk about anything else? I think we've covered the list of what you wanted us to talk about, but.
did you find any of the? Like I said, for me, it was a little. Perform the test on a bigger patient, and obviously I didn't have like a table, but I think that some of the stuff is just important to know that like you may not always feel it, and it can be difficult depending on your patient, like your patient size, and I really think about like your patients who like accept like the pressure of what you're going to be doing, and I don't mean like emotional pressure, but like threshold or whatever those words are in all of our articles lately.
Yeah, so I practice on Caroline, who is probably like 5'3", $150 maybe. No, not even that. And then I practice on Greg, who is like a big hefty man, and like the thigh thrust, I had difficulties with that one. And what other one? Oh, compression. I had to get like on a step stool because I was like not tall enough.
Right.
But I was thinking, I guess if I do have a bigger patient, I don't think I'm going to get a good read on the thigh thrust, like getting my hand under there and lifting up and pushing down, that the Gangsling, it was a little bit easier because you just have them hanging off, and then I can put pressure on. That was a little bit easier, but I guess you just have to take it each patient at a time.
Yeah, like I said, it was funny because my husband was all like upset. He's like, "Are you going to talk about how it's going to be harder for you because I'm big and you're little?"
Yeah,
it's important to identify that. Well, I think it's just important to point out to other practitioners that like, don't forget, not all your patients are going to be like tiny little girls. You could have like a large person to perform this on. So be ready to lift and hoist and sweat and all of the things that go along with it. And even when we were doing some of the other tests, I mean, like it's physical movement, so you have to be ready to like. About I did the husband, and even just like holding his arm up and doing all the movements. Like by the time I was done, I was like, my arms are tired and my whole body's tired.
Yeah, I agree with that.
Yeah, I can't really think of anything else. Like I said, I thought reinforce the ideas, and I do feel more comfortable with SI joint eval now.
I do too. I feel comfortable and confident, and just if I get those 3 tests out of and don't need to keep more aware of putting my patient through pain if I'm doing more than necessary. So.
Right.
All right. Well, thanks for the good conversation and going through those techniques. It's always good to see other people's placements and thoughts on the techniques. So.
Yep.
All right.
Bearing with my tech issues.
No problem.
And my